Okay, I think that we should start. So thank you everybody for joining today to our webinar. The first presenter of today is going to be Dr. Salvatore Tedesco. He is Assistant Professor at the School of Computer Science and IT on UCC in Cork. And he's the principal investigator and leader of the research team in AI in Tyndall National Institute. And his presentation is a Power Smart Systems in Healthcare, Current Applications and Future Directions. So I leave you the place, Salvatore. Go ahead.
Okay. Hi, thank you very much for the introduction. I'll now start sharing my screen. Can you confirm that you can see it?
Yes, we can. But we see, perfect. Yeah, that's it.
Okay. Okay, so thank you very much for the introduction and for inviting me here. As mentioned, I'm an assistant professor here at the School of Computer Science in UCC, and I'm also affiliated with the Tyndall National Institute. Just to give a little bit of a background about Tyndall, it's the largest ICT research center in Ireland with over 500 researchers on a number of multidiscipline areas like microsystems, micro-nanoelectronics, photonics, etc. It is based in Cork and in Dublin, and it focuses on a number of application domains like healthcare, communications, energy, and agritech. Within Tyndall, I am also part of the human-centric system cluster, whose vision is to enable interfaces between humans and the digital domain by developing next-generation sustainable human-centric system, ICT, so looking both at hardware and software and by co-design. And that's quite important because, because these can give us information about the impact of exposure of the human bodies to our surroundings. This can be done at work, at home, or in our daily environments. So human-centric system, basically, they are a bridge between the analog and the digital world, and they basically are an interface between the users and the physical world and the cloud, which provides basically services and insight through all this data. In order to do that, there are a number of technologies and building blocks that are required to achieve that, which includes, for example, flexible electronics, smart communications, smart antennas, for example, and AI on the edge and data analytics. And that's specifically the area I'm leading. The vision for the team basically is to develop intelligent, scalable AI-driven systems which can transform industries through applied AI and by making a decision-making process directly at the edge. And this can be applied on a number of application domains, from digital health, sport analytics, physiological monitoring, agritech, robotics, communication, etc. So here it's part of my team, which consists of a number of PhD students, postdocs, and research engineers, and we have a large network of external collaborators, both at clinical level and at computer science and engineering domain. Our team has been recognized at national level with different awards, and I've been put together quite a large infrastructure which can be used for human motion analysis. This consists of a number of gold standard technologies like camera-based systems, motion capture systems for data collection, physiological monitoring, for example, EEG, EMG, PPG, ECG, etc. We also have optoelectronic systems for camera for human motion analysis. Also, other technologies like pressure insoles, force platform, pressure mats, etc., and also systems which we can use outside of the lab, for example, for free living settings, the data collections. So we use all this infrastructure both for validating the type of hardware custom hardware that we developed and to validate against gold standard technologies, or for collecting data that we use for building our own AI models for the different applications. And this we also integrated this with another couple of labs which we can use for electronics prototyping and characterization, and for mechanical prototyping and system integration. And there are a number of projects in which we use all these type of skills and expertise. So we have developed systems, smart garments systems. Here, for example, for with a multi-sensors approach for improving the adherence and the motivation of subject undergoing through knee rehabilitation after surgery, or the development of a smart garment, which is used by athletes in order for implementing a physiological monitoring, which could be used, for example, for predicting muscle injuries. We have been using acoustic emission sensors, for example, in order to estimate the risk of knee osteoarthritis. We have been using, again, other type of physiological monitoring, for example, EEG for prediction of chronic migraine, the use of PPG for stress detection, the detection of blood pressure from different areas around the body, for example, and work around fatigue, muscle fatigue estimation, and the use of wearable sensors in hospital environments, for example, to support mobilization. And finally, also another example where we developed a custom-based smart glove, which we used for virtual reality type of scenarios. So quite a broad range of projects and skills that we have been working with in the last 5 years, but I'm not going to talk specifically about each one of these projects. I'm going to focus only on one project, just to give you a flavor of the type of expertise that we have. This is a project that was completed recently, which is about a novel remote monitoring solution for people with Parkinson's disease. So why Parkinson's disease? Is better because it's a chronic neurodegenerative disorder which affects, is known to affect mostly motor capabilities. There are at the moment 10 million people worldwide affected by this condition, which is expected to increase up to 17 million by 2040, and then that's a huge cost in terms of direct and indirect costs. So only in the US per year is going to cost approximately 50 billion, which is going to increase as well. Now, I mentioned before that Parkinson is mostly known for motor capabilities, but there are also other non-motor functions that are affected by this condition. For example, blood pressure, which is affected by the medications taken by people with Parkinson, like levodopa. So we have realized that on the market there are only systems which can provide aspects related to the motor symptoms in Parkinson's disease, but there is no actual device which can be used to collect an holistic health view of the patient. For example, looking both at Parkinson's disease, motor symptoms, gait speed, sleep cycle, and blood pressure. And this could be done, for example, by collecting simultaneously data from inertial sensors, PPG, and ECG. And this could be used, for example, for supporting clinical trials, for supporting at-home therapies, supporting clinicians when providing treatment to patients. And this project was a collaboration between Tyndall, UCC, and AbbVie, the pharmaceutical company. So in order to implement this, we developed a wearable hardware, which we use, which is a couple of sensors. One were both identical. One is worn on the wrist, one is worn on the ankle. The one on the ankle is mostly used, it's only used for the gait analysis part. If you're not interested in the gait analysis, you just need to rely only on the wrist-based device, which will include, again, inertial sensors, PPG, and ECG. And the battery can last from 4 to 7 days between charges. So can actually collect and be used as a data logger for quite a long time. Here it's an example of the software pipeline that we have developed for this. So we collect our own data, we process our own data. So we implemented some type of pre-processing. Out of that, we estimate and extrapolate specific features. And you can see even visually here an example of, for example, specific features in a subject with tremor and a subject without tremor. You can see the difference even visually here. Then we provide these features as input to our machine learning model, and we use these models to make our own predictions, for example. Here it's an example of the deep learning models that we have developed, for example, for estimating bradykinesia or tremors. And also, we were working on the development on the estimation of blood pressure in these people with Parkinson. Here we can see an example of the waveforms that an ideal PPG cycle should have. And here it's waveforms that we have actually an actual PPG waveforms collected from our own device. You can see the level of similarity between these two curves. And then we can use these type of information waveforms to extrapolate these different features, which can be used for temporal and morphological information of these waveforms. And again, we can give these features as input to a model for our own predictions. Here we can see an example of how our model, our device could be used for collecting data also outside of the lab for over 24 hours. And we can compare this against the patient diaries throughout the day. So if we look at the lab clinical data or clinical study, where we collect our own data by simulating free living environments conditions, then we can have quite a relatively good accuracy with prediction estimation of above 75–80% of accuracy, and with relatively good estimation as well of blood pressures. But then if we try to implement also these models outside of the lab in the home clinical studies, our own performance drops a little bit, approximately of 20%, but this is due mostly to the fact that we are using a patient diary as a ground truth, which is unfortunately not granular enough, because we have to record this patient diary every 30 minutes, and this is done by these patients themselves or their caregivers, which is unfortunately very problematic. And so unfortunately, there is no other, or we're trying to define a better way to have a ground truth for our models when looking at outside of the lab. So we have also been quite lucky in terms of fundings, specifically in this area. We've got funding from RCAB for healthcare in order to develop a spin-out out of this project, and also we've received funding with the North-South Research Program, which includes a number of universities both in the Republic of Ireland and in Northern Ireland, in order to work on the development of let's say, development of the investigation on the use of wearable systems for mental health in people with Parkinson's. So just to summarize about some of the possible emerging research areas, I hope that I gave some hints about how hardware and software and AI co-design could be used for a number of conditions, for healthcare, sports, rehabilitation, wellness, which can be used again for example, for monitoring physiotherapy, for virtual rehabilitation, for prediction models, injury risk estimation, emotion recognition, etc., etc. And so this could actually work towards the direction of personalized and predictive models, not only for the particular course, but also for the general populations ideally. Specifically, what we have been focusing on is on the development on the AI part, but we want to go in the other direction of where other people are going. So we have seen how in the last few years there has been an exponential growth in the complexity of these AI models, which is quite we deemed as unsustainable from an environmental perspective. And so our goal was actually, can we develop very edge AI, extreme edge AI solutions, which can actually be trained on very small amount of data, and could be work on low power devices in order to provide huge energy and latency benefits. And there are a number of challenges that needs to be sorted in order to achieve that. On-device learning is probably one of the main ones, where again, the idea is to try to learn from very limited amount of labeled data to minimize as much as possible the interaction of the user in assisting for this labeling process, how to perform continuous labels, continuous learning, so how to allow the models to adjust over time, and how to build models which are consisting of very low complexity and can run on low power devices. And we have a number of projects working on this. Here is just an example of a European project. I know it's not about healthcare, it's about agri-tech, where we actually use this a model specifically which takes images of insect of a trap, for example, and we use this for counting the number of specific insects that we're interested in and for segmenting this particular image. And this model is extremely efficient because it can run on simple microcontrollers. Has been squeezed so much to be able to run on simple microcontrollers while keeping the level of performance and accuracy on par with state-of-the-art models. So this is an example of the direction where we are going at the moment. So With this, I want to thank you for your attention and feel free to ask for any question.
Thank you, Salvatore. Yeah, so everybody, Salvatore, I think that you cannot stay for the Q&A, isn't it? At the end.
I'll try to stay. If I mean, I have a hard deadline in 45 minutes, so I'll try to stay as long as possible.
Super. Yeah, but if we don't get all the questions for Salvatore, there will be a form at the end in Teams, but in Microsoft Forms, so you can post your question for Salvatore and he can answer later through email. See if we don't get the chance to answer all these questions. Okay, thank you, Salvatore. Sure. So we pass to the next presenter and we try to get all the questions answers at the end. Let me just for the next presenter, we have Mrs. Antoinette Doherty. She is registered Advanced Nurse Practitioner, and also she is part of the Respiratory Integrated Care and Health Service Executive from the Health Service Executive HSE in Ireland. And her presentation is Care Without Borders, Leveraging Advanced Practice, Digital Innovation, and Patient Empowerment. Thank you for being here, Antoinette. I leave you the floor.
Yeah, good morning. How are you? I'll share my slides and then I'll start, okay?
Perfect.
Thank you. Perfect. I hope you can see that. I'm Antoinette Doherty. I'm an Advanced Nurse Practitioner. I'm part of a team that's called Respiratory Integrated Care. We're based in the Chronic Disease Management Hub. It's called the Errigal CDM Hub, which is after the main mountain in Donegal, which is the Errigal Mountain. And that's the image you see behind you. So we live in a beautiful part of Ireland up in the northwest. And we have a 93% land border with the United Kingdom and 7% land border with the rest of Ireland. So we're very much like a little island up here in the northwest of Ireland with a population of 170,000 and one general hospital. So this is the story of how we affected change in the care and management of people with COPD. Just bear with me 1 wee second. Sorry. There's somebody outside, a very loud thing going past the window.
No problem. We cannot hear it, so don't worry, Antoinette.
You can't hear it. That's okay. I am just, I can see my slide. Okay. So I wanted to tell a little about COPD, chronic obstructive pulmonary disease. There's quite a significant burden. 2 wee seconds. You can still see my slides. Can you still see them?
Yes, we just see them in the...
I've sorted my problem out now. It affects there's 3.5 million deaths globally in 2021. So it's a significant preventable cause of death, and it affects 12% of people worldwide. So there's huge economic burdens on the Irish and European healthcare, not to mention individuals' quality of life burdens of care. So at Letterkenny University Hospital, we had the highest national readmission rate at 28.7%. Following discharge, within 1 month, 28.7% of our COPD patients were readmitted. And there was a time in about 2020 that 42, nearly 43% of all medical beds days were assigned to respiratory patient care. So there was a high level of respiratory disease in the northwest, and our patients were being admitted time and time again. So as part of an advanced nurse practitioner pathway, you get to identify an area that you would like to change for patients' benefit. And I had known for a very long time the problem we had with multiple readmissions with the same group of patients, and there seemed to be a lack of an alternative pathway. So the first thing I did, and this was just before the pandemic, I conducted an audit of inpatients at Letterkenny University Hospital, and I focused on patients with multiple admissions for COPD. And during the audit, I met a lady with Margaret, and when I reviewed her hospital records, I found that she spent 60 days in hospital over the last 12 months, and 7 of those admissions had all come through the emergency department. So there was multiple people like Margaret, with months of hospital stay, time and time again, they were coming back to the hospital, and nothing was changing. When I asked Margaret, what happens when you get sick, and do you go to the doctor, and trying to understand the problem? And she said, no, I don't bother, because I always end up in hospital. So essentially, I wait until I'm sick enough and I call an ambulance. So I knew in my heart this wasn't ideal and something was wrong, and the time had arrived for change. That it confirmed the problem was greater than I had initially thought, because I had never really asked the patients why, and now I understood the problem. One patient told me they had phoned their general practitioner 26 times before they got through, and they wouldn't always get an appointment on the day that they were sick, so they would be delayed in getting treatment. And she just felt hopeless and, kind of powerless to the problem. But before I could do anything, everything changed. It was April 2020. I was redeployed to the local COVID assessment hub. So we have 45 GP practices in the county of Donegal, and those GPs sent their patients to us to be assessed. Anybody with a respiratory symptom. We were very fortunate. We got to use Bluetooth-enabled technology and an app, which we were able to provide to patients. Instead of going to hospital, we were monitoring patients who had symptom burden of COVID, but where there was no beds in the hospital, or they weren't sick enough to go to the hospital. So over the next 14 months, we monitored 200 patients. 75% were hospital avoidance, and 25% were patients who had been supported discharge, new oxygen, maybe had previously been in the ICU. So that really gave me an insight into how you could use technology with a cohort of patients. And what I found was, when you give people technology, when you provide the firsthand, I saw when you give people the right tools and the right partnership, they don't just manage their condition, they master it. These patients with COVID-19, they were monitoring themselves, they were making decisions about their care, they were staying at home. So 4 times a day they got a prompt, and they applied the oxygen saturation probe to their finger, and the data was transferred over by Bluetooth, and I was able to review that data here in the hub, and that those patients then, if there was an escalation in care required, were able to activate that. So as an advanced nurse practitioner, I knew what was required now to assist the patients like Margaret, because I had that experience. We needed to develop an alternative pathway for COPD. The problem was, up until this time, we had a reactive hospital-based model of care. There was very little patient empowerment, and as we saw from Margaret, she just waited till she got sick before she would phone 99 and come to the hospital. And we had the highest national readmission rate. So the numbers stacked up to say we weren't doing well with our current model of care. We imagined a home-based model of care. Continuous respiratory rate monitoring was really important, because in my experience with the technology, I had saturation, I had pulse, and I also had breathlessness symptom burden tool for the patients to complete. But I felt that when I was monitoring this group of patients, I wasn't able to see the work of breathing, which often increases when a patient is deteriorating. So I found that a negative. So when we were designing our solution, we really wanted respiratory rate. We wanted a nice digital app that would give remote clinical oversight. And we also wanted to have prescribed antibiotics for the patients, so they would be able to identify the signs of change sooner and implement the therapy, and that would ultimately reduce the level of the infection. So this was the vision, and we had a strong concept of patient partnership, education, and we wanted really to empower our patients. So we were taking very much Margaret's challenges and turning it around. So I'm moving on quickly. We developed a proof of concept in 2022. So really what we were doing was, could this work? How would this work? What would this look like? So we got the technology, we built a basic app, and we monitored 15 patients over a 3-month period. We framed a challenge statement as part of our design thinking process, and that challenge statement was, how might we empower patients with exacerbating COPD become a partner in the management of their health and ensure they receive the right care at the right time, as close to home as possible? We were incredibly lucky. The proof of concept demonstrated clinical success. We didn't have any hospital admissions during that time. We had 18 exacerbations. There was an economic impact calculated also, and the level of self-care and management, disease understanding and quality of life measures that we had measured before and after the intervention, all of those had significantly improved. So we were fortunate that we did an economic evaluation, because that gave us ammunition going forward when we went to apply for more significant funding. So the journey to improve COPD now became a challenge of the Respiratory Integrated Care team. Annually, we spent about 90 million euros in Ireland on hospital bedded care for COPD. As I've mentioned, we had a really high national readmission rate. We have an emergency department that's always bursting at the seams, and there's a delay for beds. In the post-pandemic era, our patients' attitude towards care had changed. They really didn't want to go to hospital, but they had now become more tech savvy. So they were open to the idea of using technology to monitor their health. We were successful in the early part of 2023 and received a significant funding from Sláintecare to set up and develop a 2-year project that developed a virtual ward similar to the project for patients in County Donegal with COPD. We went back to the drawing board and we entered into design thinking. We kept our challenge statement, and this photograph depicts our patients and multiple stakeholders in the designing of the ward. There was 5 months set aside for designing. So it was a virtual ward that would allow patients to receive care at home, supported by technology and avoiding the need to go to hospital. Respiratory rate was one of the most important factors for us, because it's a really good physiological measurement and it predicts a deterioration in the clinical condition, and it was central to the design of the ward. So on World COPD Day, we opened the ward, our 20-bedded ward, and this is part of some of the technology and what the profiles look like. So it was Bluetooth enabled. There was a digital app and a really well-designed dashboard that had multimedia content that was designed to increase knowledge and understanding in and around the condition and identification of deterioration. Each day, the patient answered a questionnaire and transferred their clinical data. And every day at 12:30, as a team, we reviewed the data and made our decisions based on the patient's status at that time. So we went about bringing on patients with high levels of care and multiple admissions. We thought if we trained these patients up in the technology, that when they were sick in the emergency department and we wanted to support them early to leave hospital, they would have the insight on how to use the technology, because they would have done that when they were well. And that worked really, really well. About 50 of our highest care users were trained on the technology. So in the year that followed, they were just automatically in the emergency department, and then they would be transferred over to the virtual ward as an early discharge or complete hospital avoidance. We opened the doors then after in the new year of 2024 to GP patients with active exacerbations, and also any member of the respiratory team if they were in the emergency department or in the outpatients department and they identified patients who were sick and needed a bed, but rather than send them to the hospital, they could send them to the virtual ward. So we have multiple referral pathways onto the ward. And that's actually in itself kind of made the acuity of the patients different levels. So you didn't have all high acuity patients. You had maybe a quarter very high, half medium, and a quarter low acuity, maybe on the virtual ward for improved knowledge and understanding in respect of their condition. This is what the kit looks like. It's a piece of wearable technology, not unlike a Fitbit watch the patient wears. It picks up respiratory rate, heart rate, oxygen, temperature, sleep activity, and going into the future, you could add in the cardiac component, but at the moment, this is a respiratory ward, so we concentrate on those values. That's the Samsung Galaxy tablet that our patients use. This is what the patients would see. It's their daily questionnaires, and they're very, very simple, and everything is one click, one button transfer, really patient-friendly design. This is what the multimedia content app looks like, and there's information there on how to optimize airway clearance and breathing and so on. Next slide looks like a profile. So this is false data here. This isn't a real person, but this is what the profile of the patient. And on the right, you can see this patient has green values, respiratory, oxygen, and pulse rate. And as the patient changes, those values would change to red, amber, green. This is a respiratory rate trending upwards. So I would see the trend upwards, and I would know that patient information has changed. I think I might have about 3 more minutes. I hope that's okay. 12:30 I've already. Am I okay for time?
That's fine. Yeah, don't worry.
Yeah. So at 12:30 we have our multidisciplinary team virtual review of the patients onboarded. So because Donegal is a large county, north, south, east, and west, there could be a nurse or a physio closer to the patient geographically, and that nurse would be assigned if there was a care, physical, face-to-face episodic care required for that PM. So that really, really worked well. So we were, to me, this project really standardised care throughout the county, but it also improved communication. And we were a service that ran scheduled care, and now we were doing unscheduled care. So there was a great bit of work in respect of changing our practices. Within 10 months, we had dramatically reduced the readmission rate, and we brought it down to 13.9%. We exceeded all expectations. About 22% less patients were presenting to the emergency department with COPD because they had an alternative care pathway. So we were able to see firsthand the impact that this was having. Because it was a Sláintecare funded project, we had a lot of stats, and the app was designed to generate the stats. So we were able to calculate healthcare usage and economics in respect of this. So there's a great piece of research to be done in the future, and I hope to complete a systematic social return on investment on this project. This is a pathway. So we have the patient. It's very much a scalable, replicable framework that could be used anywhere. It could be used in other rural settings or in urban settings. We were really fortunate. We were acknowledged as a HSE Excellence winner for patient experience in 2024, and now you can see the team behind. And the last slide is happy birthday, John. Before care, John he was not unlike Margaret. He had multiple admissions. He had about 6 admissions, and he came to care. And the year he started to have care as his number one place to be treated, he had all his admissions at his home, surrounded by his family. So for John, quality of life looks like walking hand in hand into his 80th birthday party with his granddaughter. So for us, it was very much about the patient, and they were very central to everything we did, and we listened to them, and we evolved and adapted our process throughout the 2 years. And now we've actually been funded for an additional 7 months, and we're hoping to get funded into 2026. So it's become, what was started as a project has now become, mainstream care here in Donegal. So that's the project, how we changed the care management of patients with COPD using digital technology, kind of evolving integrated care and creating an alternative to hospital-bedded care. Thank you.
Thank you, Antoinette. It was a lovely presentation. Thank you. Okay, so we leave the questions by the end, yeah? And we are going to pass now to the next presenter, and then we get all the questions for everybody.
Perfect.
Thank you. So, yeah, let me just introduce our next presenter. 1 second. So, our next presenter is Dr. William Farrelly, Principal Investigator and Lecturer at Atlantic Technological University, and his presentation is Enhance the Live Experiences for Older People through 360 degrees video. Thank you. I leave you the floor, Billy.
Okay, can you see that? Can you see the shared presentation, Carla?
No, not yet.
I have shared it.
Yeah, now.
Yeah, okay. Good. Okay, just let me. Okay, good morning. And thank you very much for inviting me to to give a presentation at this meeting. So I'm going to really begin this presentation with a story. My mother was in palliative care for some months, and I remember that winter was very cold and there was snow on the ground, and my mother wanted to go out and play snowballs outside. So after careful considerations with her care team, we wrapped her up in blankets, found a wheelchair and took her outside. In the heavy snow, we played snowballs with each other for about 15 minutes. And for a moment, she wasn't an ill person. She was just simply my mum alive in the cold. After my mother passed, I was walking with a friend who said something that stopped me in my tracks. So she said, "You're a technologist, so why don't you bring the outdoors indoors to your mum?" And that question changed everything. It's the reason we're here today. And we really can imagine how technology can restore experiences that we once thought were impossible. So let's begin. Okay, the project that I'm hosting today is called Enhancing the Lived Experience of Older People Through 360 Video. It's a collaborative project between the ATU, the WISAR group, Data to Sustain Funding, and RemoTED. So let me introduce the team. My name is Dr. William Farrelly. Of course, I'm a lecturer in computing at the ATU in Donegal. That's me second from the left. Lucas Kupchik is my researcher. He's doing a PhD with me at the moment, and he's also at the ATU Donegal. Luke Gavigan is on the right-hand side. He's director of RemoTED Healthcare, and without Luke, this project wouldn't have been a success at all. And Dr. Stephen C. Wright represents Data to Sustain at ATU Donegal, but he's not in this photograph. So the purpose of today's chat is to share some insight into how virtual reality and 360 video is transforming the lives of older people. So technology is always perceived as the domain of the young. However, our work demonstrates that immersive technologies can have potential to impact the well-being of older adults. So instead of talking about the technology right now, we'll talk about the experiences from some of the people that have gone through the VR experience. So John took an experience of a day on the farm. So once seated comfortably, the VR headset was placed on John and the video began. He reacted immediately with interest and engagement, commenting that there's a lot of cattle and they're all different colors. And we asked him, did he hear anything in the environment or did he see anything in the environment? And he said, yes, I hear a tractor behind me. He looked around and he said, that might be my brother driving it. John's background was as a farmer. So, and he was also asked, could he see anything else in the video? And he said, yes, I see a man in blue. This was identifying the farmer in the video. So the observations at the bottom of these pages that we're going to discuss are coming from the nursing team. They're not coming from the research team at the ATU. So their observation was that John responded very positively to the VR experience. It stimulated memories, encouraged verbal engagement, and noticeably enhanced his mood and well-being. This activity appears to have therapeutic value for John and could be beneficial for future sessions. So that's one of the people. We'll just look at another. Okay, so Marie was a stock car enthusiast when she was young. And Marie used to go out stock car racing with her husband when he was alive, and she would do the navigation. So Marie participated in the virtual reality experience of a fast car ride paced on an American dirt track. So from the beginning, Marie was visibly enthusiastic and engaged with the experience. So she said things like, it's very exciting, it's very dangerous, but it's exciting. I know it's not real, but it's good fun. So Maria laughed and reacted appropriately to the sudden twists and sharp turns, leaning significantly with the motion of the car and showed clear enjoyment. And in terms of the observations from her care team, they said that Marie thoroughly enjoyed the experience. She remained animated and engaged throughout, demonstrating both a strong sense of presence and appropriate emotional responses. And then there's John. John was a patient that, or a resident in the care home that was living with chronic pain. But John is a very capable individual, and he's very tech savvy, and he can easily adapt to all of the visual experiences from the VR system. So he's been exploring things like trip to Egypt, a live football match in our stadium. He's gone to Milan, he's gone to Rome, he's gone to London, and he describes the experience as absolutely fantastic. So he lives with chronic pain, and he demonstrates independent and effective use of the VR technology. He gains clear emotional and psychological benefit from these sessions, including increased contentment and distraction from chronic pain. So we think that that VR experiences distract people from the pain that they're feeling, and we're also trying to introduce this into palliative care units. The last person here is Romantis. Romantis took a trip to a tropical island, and before the session, he was very agitated, was somewhat grumpy and withdrawn, and but the experience, after the experience, staff noticed a clear and positive shift in his mood. Now, Romantis showed a remarkable improvement in mood, appeared more relaxed, alert, and content, and his engagement throughout was consistent, and he seemed to genuinely enjoy the peaceful, sensory-rich environment. So the observation again from the health team were that it helped lift his mood and provided a sense of calm and enjoyment. So the project, as I said, was a collaboration between the Atlantic Technological University and Reata Healthcare, and it was funded by the Data to Sustain program under the Test Before Invest program. So what do? Well, we developed a set of training videos that allows carers, nurses, and relatives of residents to create 360 videos for themselves and for their patients. To edit those videos and then transpose the videos onto a VR headset where a resident can enjoy a virtual walk in the country. These are some of the experiences that we have given to residents: a walk on the beach, a shared experience with the family dog, a walk around a farm, and the experiences can be tailored to individuals or groups. We did an interview with Highland Radio shortly after the first trial, and that had a lot of impact on the local community. We have had several people contacting us since looking to do the same sort of thing. So what were the key findings of our research? Well, there's basically two key psychological benefits to using VR as a mechanism for improving quality of life. The first one is enhanced emotional well-being, and the second one is cognitive stimulation. And we also think that there's a number of physiological benefits that we could measure as a result of doing experimentation with VR as well. And these include putting wearable sensors onto people's limbs and determining over the long term if there is a physiological benefit. But we haven't done that research yet, and we just don't know what the outcome is. So were there any challenges, and what were the lessons that we learned? Well, yes, there are some challenges around technical accessibility. The devices themselves need hand controllers to operate, and the hand controllers for older people seem to have some difficulty. So we're trying to team up with other people who can develop hand controllers that are much more user friendly and much more people centric. There's also a very small percentage of people that experienced mild discomfort in a VR environment, and we think that the mitigation for this is to choose appropriate content and limit session duration. So in terms of what we can do, the videos that we have provided train people to make videos for themselves, but you need to invest if you are going to replicate the work that we've done. So we are recommending the Oculus MetaQuest S3. And we're also recommending the 600 ampere battery that sits on the back of the device, and that's to balance out the device on people's heads, particularly older people with frail necks. We're also recommending the Instacam 360. It's probably the best 360 camera that's on the market at the moment. So for an investment of approximately €1,039 and access to the training videos, a care home could begin the process of introducing 360 video experiences to residents. So where has all this led then? It's led to a PhD scholarship funded under the TU RISE program in Ireland. And as part of that program, there's a sub-program called Thrive. It's a translational health research, innovation, prevention, and equity program. And the title of the PhD that we are working on at the moment is the integration of virtual reality and artificial intelligence to reduce the impact of loneliness in older people. So what we're trying to do is introduce an avatar into the VR environment with attached AI intelligence, so that the avatar over time will become a companion to the people that experience the VR content. So in conclusion, as we continue this journey, we advocate for wider accessibility for this technology, ensuring that all older people, regardless of circumstance, can actually benefit from this technology. Thank you very much for your time. Are there any questions?
Thank you, Billy. Thank you, William. It was very nice presentation. Thank you to all our presenters. They were very interesting examples of technology in Ireland. So now we are going to pass to the questions. We have, I think, one or a few in the chat first. I think, yeah, the one that I see here is, in the case of the COPD study, have you duplicate this model into other patient groups, such as atrial defibrillation patients and coronary heart disease? That's the question.
Yeah, that is the next hurdle for us here in Donegal, because our patients just don't have COPD and have other comorbidities. So during the month of September, half of all the patients we had on the virtual ward had some element of heart failure. So we were accidentally, by accident, having to monitor fluid levels and blood levels and different things like that. So definitely, it goes without saying, it's a fantastic model of care, and any chronic condition, whether it be cardiac or diabetic background, would suit this model of care. So I can see that happening within the next 6 months.
Okay, thank you very much. Any other questions from the public that would like to make? Anybody a part of that question? I don't know if there is someone that would like to make a question. Okay, so I have a question. So, in the case of your study, Salvatore, with who you are doing this project of the Parkinson, and what effect you have seen in patients, and how can it has been helping healthcare in this organization that is working with you?
Yeah, so I mean, the best study specifically was done in collaboration with UCC, the Center of Gerontology and Rehabilitation, which has a strong links with Parkinson Ireland. So in the development of this device, we took into consideration a lot of the feedbacks and comments coming from the stakeholders, so basically the end users. So they were quite happy about the system that we have developed. And at the moment, there is another paper that it's under review. We ideally is going to be finally published next month, which was specifically looking at the user experience of our own device on patients, which was highly favorable. They see this device as a very groundbreaking for them, to help them monitor and in some way manage their own conditions. And so positive, there was a very positive feedback on the technology overall.
Okay, thank you very much. And in your case, William, one question I have is, so what is necessary to you start to partner with with people to do this physiological monitoring? Are you is part of the PhD or you is other line of research?
It's both, Carla. It's both part of the PhD and part of another line of research. So we're looking at we're looking at a combination of mechanical engineering, electrical engineering, and psychology, really, and physiology, in order to get people to move their limbs along with these pace that that they're pacing, and to feed that information back into some sort of a pneumatic device that will adjust to the pressure so that we don't break any bones or do stuff like that. And also that feeds, then we can put sensors on limbs and so on and monitor over a period of time to see if those if that data is going to show anything.
Okay, thank you very much. And go ahead, Antoinette.
Yeah, so my question's for you, William. We both share
Yes.
the same, we're working in the same county, and I've
Yes.
heard of your research, and I know it's really, it's essential when you go out into the care homes and you see patients, and I think anything that brings them back, if they've been
Yes.
non-verbal and it triggers. My question is are you ready now to, can I buy it tomorrow if I worked in a care
Yes.
home? Yeah.
Absolutely, you could.
Yeah.
And like we've already got it in 2 care homes in Letterkenny.
Yes.
That we're expanding to Kildare and also to Kerry.
Yes.
So this is going to go national rather than remain local, I hope.
Please God, that's good. I'm pleased to hear that.
Yeah.
Thanks.
Super. Thank you very much. Anybody else? Any question in the public? Don't be shy. No? Okay, well, if you want, I would like to ask you to please go to the following Microsoft Forms. You can just to give us feedback to improve next webinars for RemoTED. And as well, if you have any questions and you were so shy to ask them here, you can also write them there and I can send them to the presenters if you have further questions. Anybody? Yeah, thank you everybody for everything, and
Okay.
thank you the presenters, thank you Salvatore, thank you Antoinette,
Thank
thank you William, and yeah, have a lovely day everybody, and thank you for joining. Thank you.
Bye.
Cheers.
Thank you.
Bye. You're welcome. Bye.
Thank you.